This is going to be a joint presentation between me and Jesse. I'm including some video along with the slides, so I wanted to make sure that we saw this. Jesse gets 75% of my honorarium. He's that good. So the title of the presentation is the Asthma Adherence Pathway, which is an app that I developed, which improves adherence, quality of life, and outcomes in both children and adults with asthma. I'd like to start out this. You've just heard all this about me. I guess the focus that I spend a lot of time is in the area of education and training clinicians on how to be effective in promoting adherence. And we're doing asthma and adding COPD to this mix. And I have an adherence training program at the Christiana Care Hospital in Delaware. I'm going to be discussing initially asthma management. Then I'm going to present my model, the asthma adherence management model. And then I'm going to show you how that model actually works. So let's see, if I click on video, let's try that. But at this point, given his hospital stay, lower lung function, and wheezing, I would strongly recommend the inhaled corticosteroid medications for him.
No steroids for Anthony.
There's a difference between the inhaled and the oral, where the inhaled are much safer to use.
No, I don't want Anthony on any steroid medication.
So just to briefly mention to you, talk a little bit about asthma. It's a chronic disease of the airways, and the symptoms are breathlessness, wheezing, coughing, chest congestion. Symptoms may be episodic or continuous based on the severity of the disease. And it may be reversible with medication, or in some cases not. And this cartoon gives you an idea of what goes on inside the airway. On the left is a normal airway where the muscle surrounds the airway and that the lumen is open. Let's see, which button do you push for the arrow? The side? Top.
You want the one on top.
So we have the normal airway lumen, which is clear. Muscles are relaxed around the airways. On the individuals having asthma, you have spasm, constriction of the airway, you have inflammatory exudate, and swelling of the lumen. And this is all due to inflammation of the airways. And it's not a casual problem, it's a continuous problem. And in individuals with mild, moderate, or severe, that determines the amount of is determined by the amount of inflammation. The key point here is when you're treating patients with asthma, you're taking it on a long time. For adults, it might be a lifetime. And the point is that it has to be done daily. The issues are you want to get a medication that reduces the inflammation that we just expressed. So these types of medicines include inhaled corticosteroids, long-acting beta agonists in combination with inhaled corticosteroids, and leukotriene modifiers. Asthma is a very common disease. In the United States, almost 26 million people, and 7 million of them are children. It costs a lot of money and affects the families and patients severely. In 2010, there were 1.8 million emergency room visits and almost 440,000 hospitalizations. So this is a significant and expensive problem. The National Institutes of Health Lung Blood Institute has come up with a 150-page report, and you can see it all now as far as what's important in these 7 messages. The treatment of asthma is the inhaled corticosteroid. You need to have the patient, you have asthma control of their disease. Each patient should have an asthma action plan, which will assist in that control. There should be regular follow-up visits. The patient and the clinician should agree on the severity of the illness so that they will then be able to match the appropriate treatment. There should be allergen and irritant exposure control. Most of asthma, or 90% of it, has an allergic basis. So having an evaluation to find out what you're sensitive to allergy-wise is important. And the seventh, what I would consider very important issue, is the concept of adherence to treatment. Now, all of you have heard of the term compliance, and you probably all have heard the term adherence. And I'm going to read you the definitions. Compliance is the extent to which patients follow physician instructions, prescriptions, and proscriptions. It implies that a treatment decision making was entirely the physician's responsibility and the patient must obey or acquiesce. Basically, do what I say. Now, adherence is a very consensual, cooperative arrangement. The definition is the extent to which a person's behavior, taking medication, following a diet, and or executing lifestyle changes, corresponds with the agreed recommendations from the healthcare provider. So it is a very joint point of view. And I'd like to take credit for Dr. Flaherty's presentation, because when you're talking about consensual, and we'll get this in with motivational interviewing, it's very important to have a sense of empathy and caring as part of the presentation. And when you're working in the context of adherence, those issues are accentuated. Now, adherence is a big deal as far as it's not like a rare disease, it's all over the place. Only 40 to 60% of patients actually follow through with treatment. There's been a study of 5,500 adults who are taking a combination medicine, a bronchodilator, inhaled steroid, and this is prescription refill data over 12 months. And what they found was, if you take all of the patients and you look at all the prescriptions, they would average out only 22% of the 365 days where the individual is taking the medicine. And more than one-half the patients of that group actually filled a 30-day prescription only once during the one-year period. This is not difficult to find. Well, we can talk about that in a little bit. It is very common. And that in another study, they related individuals who had adherence to less than 25% of the treatment that was offered were more likely, and that was to inhaled corticosteroids, were more likely to be seen in the emergency room. So it's almost a predictor. And that the cost of non-adherence has been estimated anywhere from $100 to $300 billion a year. And I think that is a very conservative estimate, because no one's actually identifying all the people that come into the hospital and whether they're adherent or not. So I've been interested in this problem since medical school, and over time have done a series of research projects and continue to do them. And I've come up with an app, namely the Asthma Adherence Pathway, that we are now testing out in an NIH study, and as well as one from Merck. And it includes 4 steps. The first is to be able to identify real-time monitoring, and we're using electronic devices on adherence on meter dose inhalers that are hooked up to the internet, and I'll show you what that looks like, to identify the patient adherence. Then we have patients complete a survey where they identify barriers to the problems that are making them difficult for them to follow through with treatment. Once they've identified it on the patient portal, then they go to the clinician portal, and the clinicians see the same responses, but they are given different and a clinical decision support strategies for each barrier, and that the individuals, the clinicians are trained in either motivational interviewing or shared decision making to enhance the effectiveness of the clinical strategies. So this is what we do. And this is, to give you an idea, back in the late 1980s and 1990s, I was a director of an asthma rehabilitation hospital, and we cared for 59 children with severe asthma. And 1 year prior to admission, their cost for the group median was $10,240. The average median was 7 hospital days, median 4 emergency care visits. They were put into a program where we identified their adherence, we identified their barriers, we looked at the family's functioning, since I have a family therapy background, and I look at medicine as a behavioral problem to solve. And then we discharged them and followed them for 4 years. And we found out that at all 4 years of follow-up, the median number of hospital days and emergency room visits was 0, and that the cost at the first year was $4,000 and dropped below $2,000 at the end of the 4th year. And the trick is when they came into the offices at the hospital, we would measure their theophylline level, because most of these individuals were taking polypharmacy, and that medicine you had to monitor, because too little it didn't work, too much they would get violently sick. And we were able to identify who wasn't taking the medicine and begin to initiate strategies, and that's how we figured it out to develop the app. So we did 2 other controlled studies, uncontrolled studies. We looked at outpatient individuals at the hospital for children, and subsequently Blue Cross Blue Shield of Delaware asked me to set up a monitoring program, so that all 3 programs, we had 70% reduction in cost. So we feel pretty promising, and so did the NIH and Merck, about funding to see if this thing will work. So the really 4 things you need to know about taking care, figuring out whether your patients are taking the medicine or not. First, you have to identify whether their adherence status, and you have to identify the barriers. Then you have to have the strategies for each barrier, and you have to be able to deliver it smoothly. And there are lots of different ways to measure adherence. The ones that really aren't too effective are the ones asking the patient, having them fill out a questionnaire or a diary, since they tend to overstate their adherence. We use electronic monitors. They're expensive, but for patients who are very expensive, it's well worth the return of investment. And I mentioned with blood, you can use the theophylline, and some medications are excreted through the urine, and you can do that. But primarily, it's either the blood or electronics. So if we're going to identify barriers, these are some of the common barriers that patients will tell you. I forgot to take my medicine. Or, I'm really not a medicine person. We don't do a lot of medicine. Or, I feel really good now, so I probably don't need the medicine. Or, the medicine you gave me didn't work, so there's really no point in me continuing. Well, this is just the tip of the iceberg. The Global Initiative for Asthma, GINA, is a European group, and they have printed their guidelines, and here, listed on the slide, are what they identify are a comprehensive list of drug factors and non-drug factors associated with adherence. Difficulties with inhaler devices, awkward regimens, concerns about side effects and cost. As far as non-drug factors, not understanding the rationale or reason to take the medicine, fear, dissatisfaction with the providers, fears about healthcare in general, inappropriate expectations. So there's a lot more than just the big four that I presented to you. And it is the reason for that I created this comprehensive list so individuals can self-identify and not just the big four, and then you don't have to worry about missing anything, and you won't be surprised if they don't get better. So what I'd like to do now is to show you how the game is played. So this is part of the survey. It's a series of questions. One of the questions has to do with how they appropriate asthma attack. And down at the bottom, and you can't really see it, there's a question is, I start treatment without delay. And this lady was nice enough to select never. And when someone selects something that is sort of on the problematic side, you sort of put that in your head, or at least it's in your computer, and you can begin to see what's going on. So this individual is an adult. She's had, I don't know, let's see, I do know actually. She's had 3 hospitalizations the year prior, total number of 20 hospital days. She's really depressed. One son committed suicide, and he was a drug addict. She was concerned that her younger son was going to have the same fate. She's very depressed. She saw a psychologist, a psychiatrist, a social worker, and I show up. So what we did is we gave them a tracking device, and this shows what the peak flow values are daily. So peak flow is a way to blow into a device at home and measure your lung function. And you get the feeling that things were going, okay here, and something bad happened here. Well, when we make rounds, we just make rounds the old-fashioned way. Next patient, and just push the button. So when we saw this, we started to get, I wonder what's going on. So here's a listing of how her medicines should be operated upon. This is a beclomethasone, an inhaled steroid. And this is 4 puffs a day is expected. And she was doing pretty well. And then she cut it down to 2, and then she stopped. That was coincident with the time when her lung function went down. But it gets even more interesting when you take a look at her rescue medicine, her beta agonist, which is not to be taken every day, but only taken when they're having a problem. And this individual was, jumping along here. And then all of a sudden, she stopped using as regularly the beta agonist. And this was interpreted as she was sort of giving up. And this would then lead to her hospitalization. So we saw this, called up the family. They lived a couple hours away. Although her husband was very estranged, he was willing to drive her up to the office. We treated her in the office for, I guess, about 7 hours with nebulized medicine, injectable medicine, and she felt better. And we were able to intervene and prevent not only an emergency room visit, but a hospitalization. And when she goes in the hospital, it's 6 or 7 days a clip. So that's the reason why Blue Cross thought we were pretty good for them. So the next issue is once you identify the barrier, then you have to have an appropriate strategy. And then once you have the strategy, you can optimize the communication skills. So I just want to say a little bit about motivational interviewing, and that it is something that is patient-centered, and caring and empathy are a key component of this process. And it really focuses on patients who are ambivalent about treatment. Should I take the medicine? Should I not take the medicine? I don't know. She told me not to take the medicine. He told me to take the medicine. So people are on this continuum or a swing. Some people are not swinging. They're definitely not going to take it. Some people are always going to take it, but there's a large group of people who are ambivalent about what they're doing. And that the practice explores reasons for and against change. This is the reason for, This might be the reason against. Let's work it out together, understand. And it's designed to enhance intrinsic motivation. So from the compliance mode, where you say the patient must change, really, you're working in a situation where you're building motivation and confidence to help the patient resolve the ambivalence, move them along a continuum of change. And this doesn't happen just with one visit and you're out. Sometimes it takes 2 visits, 3 visits, sometimes it takes even more. But by recognizing that there is a continuum, that there are tools you can use to help people move them to resolve their ambivalence, that's the key point here. And when you evaluate ambivalence, you have to say, well, what are the pros and cons of change? Let me go backwards a little bit. No, let's talk about, just say, ambivalence is very common. Ambivalence is normal. It's not pathologic. It could be at the far end, but everybody's got it. When you're thinking about getting married, some people had ambivalence about that. When they're thinking about taking a job, they had ambivalence about that, buying a house, having kids. So it's a very common thing, and that motivational interviewing is designed to help individuals understand and resolve ambivalence to change. And that's the focus of motivational interviewing. And it looks at the pros and cons of change. What are some of the good things about taking the medicine? What are some of the less good things? And what I'd like to do now, see if I can do it myself. That'd be fun. Let's see. Jesse, come on up. Earn your money. I'm all set for the video. You got a lot of buttons to push here. I'll watch how you do it. Escape. Push that and the left button and left button. So
hi, my name is Dr. Jones, from Asthma and Allergy Care of Delaware, and I'm interested in helping you and your son improve his asthma. Hi, James.
Empathy.
Nice sneakers.
You should see my brothers. They're purple and red.
His name is James, but we call him Anthony.
Well, why don't we start and talk about the difficulty you've been having with Anthony and his asthma. His doctor mentioned that he's been in the hospital twice for asthma.
The doctor wants to put Anthony on steroid medication, but I'm afraid to do so. My husband died from a blood clot last Christmas. He had been taking steroid medication for his arthritis for about 6 years. One day he tripped and broke his hip, and the doctor said it was from the steroid medication. He was in the hospital for a week and then in the convalescent home for about 2 weeks. And one day I got a phone call that he had had a stroke, and 2 days later he was dead. And now, because the albuterol and Zyrtec isn't working, Anthony's doctor wants to put him on an inhaled steroid, but I said absolutely not. He gave me the prescription anyway, but I didn't get it filled, and when we went back to the doctors, he asked me how it was going with the steroid medicine. I told him I wouldn't give it to Anthony, and he sent me here.
I'm sorry to hear about the loss of your husband. Must be very difficult. And I can clearly understand your concerns about steroid treatments. I'd like to go over what we learned so far today. So on physical examination, Anthony's having significant wheezing. We measured his lung function. The airway flow is low. It improves after the inhaled bronchodilator, the albuterol, which is diagnostic for asthma. The allergy testing, the skin testing results were negative. So we don't have any counseling advice on avoidance of specific allergens. But at this point, given his hospital stay, lower lung function, and wheezing, I would strongly recommend the inhaled corticosteroid medications for him.
No steroids for Anthony.
There's a difference between the inhaled and the oral, where the inhaled are much safer to use.
No, I don't want Anthony on any steroid medication.
Well, I guess the alternative to consider is a non-steroidal anti-inflammatory medication, a leukotriene modifier, Singulair, and we would want him to take one of these tablets at bedtime, but it is clearly not the so-called best treatment for his severity of disease. But if we go with this plan, I'd like to have him monitored his lung function with a peak flow meter, which will show you how to use. And very importantly, if he continues to have symptoms or worsens, I'd like you to phone the office here for further instruction.
We'll do whatever we need to do as long as there's no steroid medicine.
I guess the best thing to do then would be to try this treatment, and we'll see you in about 2 weeks.
Okay.
Flip back. Go to the PowerPoint and then I'll come back where the arrow goes. All right, thanks. 5 minutes. So, what you had a chance to look at then is a history using open-ended questions, make a recommendation, provide a rationale, find out that the rationale isn't acceptive, come up with an alternative, and then, although it's not your best choice, you want to make sure you have close supervision. So, 2 skills with the motivational interviewing are reflections and cost-benefit analysis. Those people who ever saw Marcus Welby or something like that, his best reflection was something like this. And that was his way of saying he was paying attention to the patient. Now, reflections are a statement, not a question. They let the patient know that you're listening. It ends with a downturn. You're checking a hypothesis. You're taking a guess what the patient is saying, and then giving them feedback, and then it affirms and validates what the patient has said. And it's used strategically for self-motivation interviewing. And there are all sorts of types of reflections, but an easy one for you to get started is to say back exactly what the patient said to you. I'm worried and frightened. Oh, so you're worried and frightened. You acknowledged what the patient's problem was. It wasn't a surprise. Might be a surprise to her if she listens to this, but that is a simple reflection and ends as a statement. The other way to deal with another interview technique, motivational interviewing technique, has to do with this decision balance, pros and cons. And you work this out specifically with the patient. And what I'd like to do, Jesse, is to show my last video example of what happened now that this patient left on Plan B. How did she deal with follow-up? Escape.
Good morning. How things work out? Hi, Anthony.
Hi.
Oh, not so good.
So Anthony's not doing so well.
Well, we did what you said. I gave him the Singulair every night. He still continued to have some coughing at night and during the day. His peak flow values have been in the 180 to 210 range, and I think you had mentioned they should be in the 240 to 250 range. I've been giving him the albuterol in the morning, and the school nurse gives it to him at lunch and before recess in gym. But she said she's worried and says that I'm damaging his lungs by not giving him stronger medication. and I'm just miserable. I don't know what to do.
Worried and frightened.
I want Anthony to get better, but I don't want to give him the steroid medicine.
You want to do the best for him.
Yes, and that nurse wants me to give him the medicine that killed my husband.
That nurse appears to have really upset you.
She did.
The nurse discussed corticosteroid medications with you?
She said Anthony needs that to feel better, but I feel like I'm in a bind.
So if I understand you so far, Anthony's asthma has caused him to have frequently missed school, emergency trips to the doctor, deficiency in not doing well in sports. But on the other hand, you're concerned about the safety of the inhaled corticosteroids.
I know it doesn't make much sense, does it?
Well, I can see how you could be confused at this point. The nurse, I think she may be right. As I mentioned to you before, there are different types of steroid medication. The oral tablets and then the inhaled steroids. And I believe your husband was taking the tablets. Is that right?
Yes.
The tablets have very strong side effects. It's well known that they can cause elevated blood pressure, ulcers, diabetes, cataracts, weight gain, just to mention a few things. And yet, the inhaled corticosteroids are relatively very safe to take. May I discuss this with you some more? I'm wondering whether we could look at the costs and benefits of using the inhaled corticosteroids. What are the costs of using the inhaled corticosteroids?
Well, I looked it up on the internet and it said weak bones, weight gain, and growth problems.
Now, for the inhaled corticosteroids, Anthony's bones won't break. There won't be an issue of weight gain. These are issues are associated with the tablet form of the steroids. The only side effects are with the inhaled corticosteroids at the correct dosing would be a possible delay in growth. So I'd like to cross these out, and let's take a look at the cost of the inhaled steroids, the issue with the yeast.
So I know that we're budging up over time. The point, what we have here now is the lady comes back and the report is not doing too well. And then there's a whole series of interactions of how she felt and what was fearful for her and being scared by the nurse. And then we go into, once again, well, let's talk about the medicine again, choice A. It's not the tablet, it's the inhaler. And now we're going to go over the decision balance, the costs and benefits. And then she's going to tell you, wow, I never thought things like that. And when that happens, that lets you know that you were helpful in letting her deal with the ambivalence. So just to close is that adherence to therapy is a very important part of treatment. A model is under further investigation, which is very promising, showing how you can identify adherence of the patients, identify their barriers, select the appropriate interventions for each barrier, and to communicate effectively. And that this process can be applied not only to respiratory diseases, but to pretty much all chronic disease. Thank you very much.